the agency to confirm on guideline. Good evening, colleagues. I'm Dr. Arvind. On behalf of Emcure Pharma, I would like to invite each one of you for today's academic fest on the management of CML in India. At Emcure, we are really proud to bring affordable, innovative, and high-quality medicine such as Next TKI, which is dasatinib tablets, for the management of your patients. And apart from products, we are also engaging with the scientific fraternity to bring cutting-edge scientific discussions for your better patient care. With this, I would like to invite our today's program director, none other than Dr. Hemant Malhotra sir. He is a renowned faculty and personality in the area of hematology. Dr. Hemant Malhotra sir is the professor and head of Department of Medical Oncology, Sri Ram Cancer Center, Mahatma Gandhi Medical College Hospital, Mahatma Gandhi University of Medical Science and Technology at Jaipur. With this, I now invite Dr. Hemant Malhotra sir, to take us through today's program. Over to you. Thank you so much.
Thank you, Dr. Arvind. My pleasure and honor to have guided this program. And I hope by the time we finish, your knowledge about chronic myeloid leukemia will be a little better. Why have we called this program the changing paradigm in the management of CML? Because CML is the commonest leukemia in our country, more common than acute myeloid leukemia, more common than CLL. And with the availability of inexpensive generic second generation TKIs, our patients now have an option of upfront starting these more effective CML treatment modalities. Of course, we still have Imatinib, but with the recent addition of generic Dasatinib and also generic Bosutinib, our options for first-line treatment of patients of CML have increased. So there are some rules which we will follow in this webinar. We have a few talks which will cover the essentials of CML. Each talk will be of 10 minutes, and my earnest request to the faculty is to please stick to time. Then we will do a panel discussion, and we will also entertain questions during the panel discussion. Those of you who have connected to this webinar, we would request you to please post your questions on the question answer or the chat section of the Zoom. And then we will take those and most of those questions during the panel discussion. So it's my pleasure and privilege to invite our first speaker, Dr. Tulika Seth. For those of you who don't know, and I'm sure that will be a very small minority, Dr. Tulika is Professor of Hematology at the All India Institute of Medical Sciences, New Delhi. And in the Medical College rankings released yesterday, the AIMS, Dr. Tulika's Institute, is ranked #1 as medical institutions in our country. And one of the main reasons why it is ranked 1 is because of this lady over here. And Dr. Tulika is going to speak to us today on the 2020 ELN guidelines, which you know have been published this year. So Dr. Tulika, the mic is yours. Thank you very much.
Okay, thank you. I'm joining from my phone, so you'll have to project the slides for me. Thank you so much.
It is on.
So, right, thank you. Next slide. So I'd like to thank the organizers, Dr. Hemant, for this wonderful opportunity. And this is actually a very excellent and comprehensive document, the ELN Guidelines 2020, and it has been written by a very esteemed body of experts. Next slide. So what's new in diagnosis and monitoring? Next. Not too much, but they've identified all the main things that we need to do when we have a new patient, and they've stated that quantitative PCR upfront is not mandatory, but we need to look at all the comorbidities to identify which of the TKIs is best for them. Next. The atypical PCR-able transcripts have been identified as a major impediment to identifying the response to patients. So it's important to make sure that your patient is not one of the 2 to 4% who has an atypical PCR-able at the baseline. Next. The definitions have been clarified of MR4, 4.5, 3 and 4 and 4.5, and they've said to avoid the term complete molecular response, instead go to molecularly undetectable leukemia. Next. The testing, which is going to be discussed further by the next speaker, has also been clarified, and the transcript numbers that we need for controls has been identified. So it's important to discuss this with your lab colleagues. Next. And it's clarified the way that we are supposed to monitor responses. And it said even in patients after MMR, we should continue the 3-monthly monitoring. And it's classified where cytogenetics is important and where it may be avoided. Next. So this is the main table that all of us use. And this has actually not changed too much from previously, except for a few of the things which I will be discussing ahead. Next. So the risk assessment, there are several new things. Next. And the ELL panel recommends the ELTS score, which is the Utah's long-term survival score. So this is an additional score alongside the 3 scores that we usually use. And this is important because it predicts the leukemia-related death in patients on TKI, because these patients don't die from leukemia very often. Next. And this assessment, as you can see, it has mainly the same categories as in the SOCAL, but with different weights. Next. And the importance is in this is that it's based on TKI treated patients, and the effect of age is negative in this because that's not very important in TKI related patients. Next. And this is just an example from the paper, and it has a link to a online scorer. Next. And it mentions in passing the implications of biopsy, which is important in 25% of our patients to define their disease and document myelofibrosis. Next. The most important thing it talks about are the additional chromosome abnormalities, which, if found at any time, make these patients high risk because they predict a poorer response to TKI and a higher risk of progression. Next. And this is where it is in the table. So at any time when they have this, this is considered to be a failure. Next. So what's new in management? Next. So when you're initiating therapy, we now have many drugs available. One of them is not available in India, but all of these agents, it says, are effective and approved in first line. Next. And it says when you're deciding on first line, look at the comorbidities, and the non-hematological adverse events should be separated into side effects, which affect tolerability and quality of life, and complications, which occur in less number of patients, but are very important because apart from the effect on health and quality of life, they may even cause death. So it's very important to look at these. Next. They also for the first time mention generics, and they say that they are an effective option for initial therapy. So generic Imatinib has been given their stamp of approval. And it says to look at the lifelong costs when you are deciding about going for a drug that will give you a sustained deep molecular response, because then you can offer TFR to these patients. Next. And another interesting thing is that it talks about the 3-month and 6-month, which was there earlier in ELM. But I think to just note is that now the NCCN guidelines will also be harmonizing with this. So actually, you're not going to be changing at 3 months. It will be changing at 3 months plus. So so most changes will occur actually at 6 months, which is there in ELN. And now NCCN has also been adopting them because that's going to be harmonized. Next. So it talks a little about failure of first line. Next. Next, please. And the second line treatment, as you know, is very important. You have to look at mutations. And one thing that I thought was interesting was that even in the absence of alternatives, it says the TKI should be considered in chronic patients who don't achieve the cytogenetic response, because they can still have some survival advantage. So again, this was something that we were doing and practicing, but now what the practice that we had when we didn't have alternatives is now also being covered in this. Next. The TKI, and of course, we have to look at mutations. So this table is very important, though it does say that for bosutinib, we don't have too much data. So some of the mutation evidence for bosutinib may change. Next. So treatment beyond second line it says that we can't really come up with third and fourth and fifth line treatment that can't be formalized. But of course, we know that, so that's pretty much there. Next. And this is a very important table where they talk about end-phase CML and the different strategies of what to do. And one of the important things I saw here was that if you have resistance to a second-line TKI, whether first line or second line, they recommend going to ponatinib, which of course may be something that we would have to see in our scenario. or it says to go on to allogenic transplant. So this is an additional table which tells you what to do with more advanced stage CML. Next. And it really talks a lot about treatment-free remission. Next. And it's treatment-free remission is included in the table. So it says that the indication definitely would be if patients are in MR4 at least, and it talks about how to monitor them and when they have failure. So all of these additions have been included into our table 4. Next. And it summarizes some of the data from the studies. Next. And it emphasizes the criteria for patients who you are planning to put into TFR. So definitely these should be first-line chronic phase patients. And then it talks about the different other criteria that you should look at when you are deciding on whether the patient is motivated and suitable for TFR. Next. And it highlights the duration of TKI therapy, which it says should be at least 5 years for Imatinib and at least 4 years for second generation TKI. And the duration of deep molecular remission should be at least 2 years. So all of these are very nicely laid out. Next. And it defines operational cure, which we had read about in some different papers. And this is different from the resistance. And it is the persistence of detectable disease, either when patients are off therapy or in deep molecular remission. And this is most likely due to immune mechanisms or BCR-ABL transcript. Next. And to summarize, this is a really comprehensive table. It gives a lot of information on different scenarios and guidance beyond first-line therapy, and a lot of information on TFR. So a very good document and very useful for all of us. Thank you.
Thank you very much, Tulika. That was an excellent summary of the very important DLN guidelines, which we've been waiting for a long time, maybe 7 years we've been waiting for that. So if you could please stick around, there might be some questions and clarifications, which we will take during the panel discussion. Thank you very much.
Okay, thank you so much.
So to continue, the next talk is going to be by Dr. Pankaj Malhotra. And I'm really honored to share the same surname with Pankaj. He had a meeting with his director, and I think he's joined, and we'll stick to our schedule. Pankaj, are you there? Pankaj, are you connected and on board?
Dr. Pankaj, can you unmute yourself?
Pankaj, can you unmute yourself?
Yeah.
Great. So Dr. Pankaj today is going to be speaking to us on essentials of molecular monitoring in chronic myeloid leukemia. And Pankaj is professor in charge of clinical hematology at the PGI Chandigarh. He is, according to his own submission, also a COVID treatment expert now. So if you have any COVID-related questions, Pankaj is the person to talk to. Pankaj, you have 10 minutes, and the screen is yours.
Yeah, so I would, from my screen, I would, make the presentation. So the topic which is given to me is essentials of molecular monitoring in chronic myeloid leukemia. Now, why do you need to monitor CML? The reason is that you want to do a response assessment. Why do you want to do a response assessment? Because of various reasons. And these are to predict long-term survival, predict cure, and thus stopping therapy, decreasing the dose of medication, need for change of treatment, and for females, pregnancy decisions. And how do you monitor CML? You can monitor clinically, you can monitor hematologically, cytogenetically, or molecular. And then we will discuss what is the frequency of monitoring. Now, just take an example that you have a car, Maruti car, and you actually want to visit from Puri to Vijayawada in Andhra Pradesh, and it takes 12 hours by a routine Maruti car. And if you divide from Puri to Brahmpur, it will take 3 hours. From Brahmpur to Vijayanagaram, it will take another 3 hours, and then another 6 hours to reach Guntur or Vijayawada. Now, let's say you start from Puri, but it takes, to 5 hours to reach Brampur, which basically means that you need another 7 hours to complete this distance. That means either you need to change your car. That means if you are on Imatinib, then you need to change to the second line TKI, or you double the speed of your Maruti 800. That means you double the dose of Imatinib, which I feel is still an option for very poor Indian patients who cannot afford the second line TKI. So this is what is monitoring. So let's go to the monitoring, and we will discuss about what is the clinical monitoring. The clinical monitoring is done by resolution of splenomegaly and resolution of extramedullary disease, if that is any. The hematological remission is when there is a normalization of WBC count and there are no abnormal or immature cells in the peripheral blood film, and the platelet counts are less than 4.5 lakhs. Then cytogenetics is done by conventional and FISH by looking at the chromosomes, and we have major cytogenetic remission and complete cytogenetic response when there are 0% Philadelphia positive metaphases. However, the problems are this is done on bone marrow samples, which is painful, and it is a tedious job to look at the metaphases, and only 20 metaphases are checked, and sensitivity and specificity increases if you look for Philadelphia in more than 20 metaphases. And you can also do from the peripheral blood, where you have to look at the 200 cells, and but it is little costlier than the conventional cytogenetics, and there can be false positive 5 to 10%. Now, the most commonly used is molecular monitoring by PCR, and is the gold standard. It can be done from the peripheral blood, and it is a very sensitive technique. There was problem in the standardization, but now fortunately most of the labs are well standardized, and they are giving on international scale. Now, once you have a clinical remission, you have to look at the hematological remission, look at the cytogenetic remission, and then look at the molecular remission. However, once the patient has achieved hematological remission, you can directly go to molecular remission also, because these days, we don't have many labs who are doing cytogenetics. Now, the next is frequency of monitoring. So clinical is and hematological. Generally, you do a clinical examination and CBC 2 weekly until the patient achieve a complete hematological response. Then you do monthly for 3 months, and after that you do 3 monthly. Whereas cytogenetics and molecular actually are done generally 3 to 6 monthly. And as I said before, you don't do the cytogenetics these days unless there are clear indications. You directly go to the molecular monitoring, and these are the gold standard. Now we come to the response assessment, that once you are monitoring the patient, what are you actually doing the assessment? The first is predicting long-term survival. So this paper, which is quite an old paper, looked at 5-year follow-up patient receiving Imatinib for CML by Brian Duker. And here, patients who have achieved complete cytogenetic response within 12 months, they did not progress to accelerated phase or blast crisis by 60 months. That means at 12 months, you could predict that this patient will do well over a period of next 5 years. And these are the graphs. The patients who did not achieve a hematological response, they did not do well. Whereas the patients who achieved a cytogenetic response, they did well. And then this paper came by David Marin, who actually looked at the BCR-ABL transcripts at 3 months, and they could predict what is happening at 8 years. So they looked at 282 patients, and the patients who achieved BCR-ABL less than 10% at 3 months, they did well over a period of 8 years. The next is predicting cure and thus stopping therapy. We know about various stop Imatinib and stop second generation TKIs studies, and this is the study, STIM-1 study, long-term follow-up of French stop Imatinib, where they looked at 100 patients, and we all know that almost 40% of patients were able to achieve a sustained molecular response. Then it's decreasing the dose of medication. So if you know that the patient is in molecular response or sustained molecular response, you can actually decrease the dose from 400 to 300 and sometimes even 200. That means that the patient will actually have decrease in the side effects, and you have good quality of life of these patients. Then if there is a need for change of treatment, so somebody who is actually not achieving the desired response, you can consider changing to nilotinib or dasatinib, and these are the tidal 2 studies as well as some other studies. And then for females, the pregnancy decisions. So this is one of the paper looking at managing pregnancy in CML. So if the preconception planning, so if the patient has durable MMR at least for 24 months, you stop the TKI at the start of menstrual cycle, conception and pregnancy, and then you monitor this patient by qPCR every 6 to 8 weekly. Whereas with assisted reproductive technology, you see the patient achieve CHR or MMR, then stop TKI, and then commence in vitro fertilization and oocyte collection and restart TKI. So this is, you can help in patients becoming, starting the family life. Now, the next question is what is optimal assessment? And Dr. Tulika has already, I think, discussed about the ELN 2020. I'll just discuss a little bit about the 2013 before going to 2020. So the optimal response was the one which is associated with long-term outcome. Failure means the patient should receive a different treatment to limit the progression, and warning is that the patient is responding, but you require more frequent monitoring. So, it's like you are driving a car and we keep on evaluating at different time points. You have a red, yellow, and green. Red basically means failure. That means treatment is going to fail in near future. Yellow is a warning. That means you have to be careful. You require more frequent monitoring and may require change in treatment. And green is that the patient is in optimal response and there is no change in treatment which is required. So at 3 months, the optimal is less than 10%. At 6 months, the BCR-ABL of less than 1%. And at 12 months, it should be less than 0.1%, which means it is optimal. And then you have, based on the levels, you have warning and failure. And anytime after 1 year, if the BCR-ABL is more than 0.1% or there is additional changes in chromosomes, that means it is warning or failure. The methods to do this is from CML 2020. So these are the housekeeping genes, ABL1 or GUS. You can take that. And this is the optimal warning and failure by CML 2020. And for patients aiming at TFR, the optimal response at any time is BCR-ABL of less than 0.01. That means a deep molecular response or molecular response of 4 or 4 point, sometimes 4.5. A change of treatment may be considered if MMR is not achieved by 3 to 4 years of time. And the loss of MMR indicates failure after GR. Finally, not everything that can be counted counts, and not everything that counts can be counted, from Albert Einstein on the monitoring of CML. So finally, concluding, the chronic myeloid leukemia is now a curable cancer. Multiple treatment options are available. Monitoring as an essential component of the treatment in the journey towards curability. And molecular monitoring of BCR-ABL gene at international scale is currently the gold standard technique. With that, I thank you very much for your kind attention.
Thank you very much, Pankaj, for taking us through the complex process of monitoring in chronic myeloid leukemia. We are aware that it is a difficult job and it's an expensive job, but it's absolutely vital for the success of treatment for patients with chronic myeloid leukemia. Thank you very much. And I'm sure there'll be a whole bunch of questions for you. So if possible, please stick around till the panel.
Yeah, I'm there. Thank you.
Very much. Wonderful. So, ladies and gentlemen, we proceed with the program, and now we have a hot debate coming up, and I'm sure the debate will generate a lot of light and maybe some heat also, because some heat, even though the temperature outside is 40 degrees, it might be a little enlivening for us. So we have two debaters in this. The topic of the debate is all patients with newly diagnosed chronic myeloid leukemia in the chronic phase in India should receive second generation TKIs. And to speak in favor, meaning to speak for the second generation TKIs, is Dr. Govind Babu. Dr. Govind Babu is my very dear friend. He is also the president of the Indian Society of Medical and Pediatric Oncology. He is ex-chief of medical oncology at the Kidwai Institute of Medical Oncology in Bangalore, and he is presently senior consultant medical oncologist at the HCG Hospital in Bangalore. So Govind, you're on now. You have 10 minutes.
Thank you, Hemant. Okay. Actually, this debate is sort of superfluous after what Hemant and Dr. Tulika and Pankaj have spoken, but let me put the whole thing in a different perspective. So the topic is second generation TKI as first line in every CML patient in India. And greetings from Bangalore. Bangalore is 21 degrees now. And sorry, Hemant, you're at 40. So, my opponent is Dr. Dinesh Burani. And in real life, if he and me stand next to each other, it will be like this. But in hemato-oncology, he's there and I'm down there. But I will show you some evidence and tell you how I can try to reach there. This is all very basic about CML. We have 3 phases that is well known. And this BCAD, what we look in the calendar, was heralded by the birth of this person, as you can make out. And in today's era, we talk of BC and AC in a different connotation before Corona and after Corona. In the CML era, I would like to talk about BI and AI. So what does this mean is before interferon and after interferon. So that is what we have. This is just to show you how nicely we have progressed in tackling the problem of CML over years. And you can see that many of our patients of CML have near normal life expectancy and they're doing well. So when you're treating CML, these are the goals. The first one is the earliest and deep response, cytogenetic and molecular. We have already seen from the 2020 ALN guidelines. To have the least amount of progression to accelerated phase of blast crisis. The third one is to have the least development of mutations. Fourth one is to maintain quality of life, manageable side effects. And fifth one is cure of patients and the new concept of treatment-free remission. So I'll walk you through each one of these and give you evidences for the same. So this is just to show you all the TKIs that we have today, and we're actually spoiled for choice. So let me take the first one, look at the cytogenetic and molecular remissions. And this is the first magic bullet, as you know, Imatinib that came in. And this is the updated IRIS study data that we have. But from Imatinib frontline treatment in CML chronic phase, we know that there are unmet needs with the use of Imatinib, which is summarized in the slide. And almost 38% of these patients don't do very well. And many other patients have problems because of various other factors. And those essentially are the unmet needs because of the use of Imatinib. And again, you have heard the importance of looking at early response. And Dr. Tulika nicely went through this ALN 2020 guidelines for you. And this IRIS data actually shows that the event-free survival at 84 months is dependent on the molecular response at 12 months. So what happens early on in the phase of the disease is reflected at 84 months and much later on. So that's an important thing that we need to remember. Not only the response, but early response is important. And this is by a paper from Dr. Jose Cortez in 2012. So we have drugs. This is data from comparing nilotinib and imatinib. And this is a 6-year follow-up data to show you how well nilotinib is doing as compared to imatinib. Similar data for dasatinib from the Decision study. And again, this is looking at MR 4.5 and showing you that this is achievable in more number of patients who are on dasatinib than imatinib. So this is actually comparing various studies of imatinib, dasatinib, and nilotinib. And again, talking about the event-free survival as long as 8 years for many of these molecules and shorter ones for the second generation TKIs. And this is one of the recent tables that I put in, which includes the data with bosutinib as well. And again, showing you that these second generation TKIs as compared to imatinib are doing much better in the various parameters that we assess our CML patients today as per the ALN 2020 guidelines. Now, why did I show you all this data? Is because early molecular response is important. And regardless of which TKI you use, early molecular response has shown that it improves EFS, PFS, and overall survival. And not just that, the future achievement of CCYR and MMR is dependent on this early EMR. If you look at the imatinib data, the response at 6 months, 87% of these patients fail to achieve early molecular response at 3 months. And you can imagine what will happen to these huge number of patients who are getting imatinib. Now, there was a study looking at switching patients from imatinib for deeper responses when you assessed at 3 months and found they were not doing well. And this is the paper of the study called LASER. And Dr. Sandeep and myself are authors on this paper. And this was a study initiated by Jose Cortes. Now, this is data to look at Ernest End, Decision, and the Baylor study. And this essentially summarizes that 1/3 of the patients who got imatinib failed to achieve EMR. So this is the next one, looking at second generation TKIs, which re-emphasize the importance of EMR. And as I've shown you earlier, achieving EMR is the key predictor for better long-term outcome. And you can see that these second generation TKIs are precisely doing that for you. Now, EMR is associated with higher rates of future MMR and MR 4.5. And this is data to show you essentially that. And this is putting in data of large number of patients. And the other way around, EMR failure is associated with increased risk of progression and death is again evidence from these papers showing you that those who did not have early molecular response failed to achieve complete remission or MR 4.5 and they had worsening of the disease and ultimately death. So that is the evidence for deeper responses and why you should get it. Now looking at least progression to accelerated phase of blast crisis, this is the study comparing nilotinib and imatinib. And as you can see that the number of progression to accelerated or blast crisis is definitely higher in those who got imatinib as compared to nilotinib. This is from the dasatinib study. Again, you can see that patients who got into worsening of the disease or disease progression is higher with imatinib as compared to dasatinib. Now, this is again comparing all the studies to tell you that there is improved responses with second generation TKIs, but survival is still not shown, probably because this is the term of follow-up with these second generations is not long enough. And also, so many of these studies have had crossovers. So let me come on to the third point, development of BCR-ABL kinase domain mutations. And this is looking at nilotinib and imatinib. And as you can see, the number of kinase domain mutations are definitely higher with imatinib. Now, looking at quality of life, we all know that each of these TKIs have different side effects, and we need to look at those to actually choose our patients, which Dr. Tulika also told in her talk. And this is looking at nilotinib and imatinib and the side effects. And as you can see, for most of the side effects, it is much higher with nilotinib. And this is one data from the comparison of adherence to imatinib use. And as you can see that with longer period of use of imatinib, the adherence decreases. And this adherence is important because that ultimately leads to the molecular responses one can have in your patient. These are the other side effects of nilotinib, and this is for dasatinib. Most of these side effects are easily handleable, and it seems that it can be used as compared to the advantages that we have. So let me come on to the third point of treatment-free remission, sustained CMR. And this is again data including the before study, all showing you that the toxicities of these drugs are definitely comparable to imatinib. So this is data from STEAM study. I'm sure all of you are very familiar. And again, telling you that those patients who had lower so-called score or those who had better responses with imatinib are the ones who can go off imatinib and stay without the drug for a long time. So this is summary of the various drugs that are there. Again, all of them showing you that there is concept of this stopping therapy and it can be translated into your patients. It is true with the second generation TKIs also. And so with all this data, I've actually convincingly told you that all these 5 points can be achieved effectively when you use second generation TKIs in the first line. Now, my learned opponent is going to tell me that duration of these studies is very short. I agree for bosutinib is less, but for Ernest and Decision, you have 6 and 5 years data. And how long do you need further? And again, with longer time, we will see this. And this happened even with Imatinib earlier on. We had to wait for almost 8 years to show that there was a survival advantage. And then he's going to tell us about dose escalation with Imatinib, and you can achieve the same. But these dose escalation studies have really not helped our patients, as shown here. There was no improvement in over half the patients. And this is from the RENICE study, again showing you that MMR was not seen with higher doses as we thought would happen. So the second point, that all these drugs are more toxic than Imatinib, I think these are not supported by scientific data. And I showed you, including the bosutinib, that these are comparable in side effects and discontinuation rates are very similar. And the toxicities are well characterized today because of the follow-up that we have. They can be easily anticipated and many times prevented. And the third point I'm sure he's going to raise is that they're expensive, yes, but if you continue them for a long time, and with this concept of treatment-free remission, if you achieve a good, deep molecular response much earlier, as is seen with the second generation TKIs, you can stop them much earlier, and therefore the costs will be definitely lesser. And of course, we are having generics, so the cost may not be really issue in India as well, because we're talking about Indian patients here. Again, data for you, showing you that nilotinib in the first line, yes, this is expert reviews. One of the second TKIs in chronic myeloid leukemia. This is meta-analysis. This is one of the most ones that I got from Jose Cortez. And
Govind, your time is up.
Quote his own work that, yeah, this is the last one. And he actually ended up saying that if he developed CML, he would definitely take second generation TKI as the first line. And I think there can't be any better argument against this coming from Jose. Thank you very much.
Thank you very much, Govind. You made a very, very strong point for second generation TKIs up front. But there is always a other side of the coin also, and to present that Imatinib still holds true and is important in our country. We have Dr. Dinesh Burani. Dinesh is DM in clinical hematology from CMC Vellore, and he is presently director of the Department of Hematology, Oncology, and Bone Marrow Transplantation at the prestigious Rajiv Gandhi Cancer Institution in Delhi. So Dinesh, we are waiting for your counter argument. The screen is yours.
Good evening, sir. Am I able to share my slides, or are they visible? Or?
Yes, you can share your screen and we can hear you.
I have shared, but I can't see. One second.
So Kalpesh, can you please guide Dr. Dinesh through screen share?
Yes, sir.
Resume share.
Yes, sir.
Is it a resume share? Share. Are you able to see my slides, or?
No, sir. Sir, close the presentation and again open, sir.
Okay, I'll do that.
Yeah. Yes.
Share screen.
Yes, sir.
Go to this.
First you open. Yes. Yeah. We'll see.
Can you see now?
Yeah. We can see. Yeah. Please go ahead.
Yeah.
Okay. I'll just say Dr. Govind Babu is my teacher. He has had many students gone through under his this thing. So whatever he has said, I will, without discussing, without arguing, will say I follow whatever he says. He has more knowledge than me, and he definitely has put a good thoughts behind it. But all the patients with newly diagnosed CML in India should receive a second generation TKI. Dr. Govind Babu will go tomorrow in his clinic and say no Imatinib, everyone should be on second TKI? probably no. When I say all patients should, the newly diagnosed CML CP in India should receive imatinib, I'm not saying I'm imatinib. We have all these 5 options, but that doesn't mean we have 4 options and no imatinib. The topic is all patients should in India should receive a second generation TKI, which I argue the imatinib also is a reasonable option. Not everyone should receive imatinib, but we have a good choice. We should not be just calling off imatinib because the other TKIs are available. As I said, these are the discussions he has put forward. The prices have come down. We have a more deeper responses, more TFI. So these are the only reasons all people should be on next generation. I will say no. These are ELN 2020. We have now discussed. I'll just read what has been written. All randomized studies comparing imatinib 400 once daily with 2 second generation TKIs, imatinib 400 with a dose increase or imatinib combined with the interferon or low dose cytarabine have failed to improve overall survival. So there is no survival advantage whatever you do apart from imatinib 400. No, another point, no new serious late side effects of imatinib have surfaced over 20 years. I think that's the best part of the imatinib. Someone who doesn't want a TFR, someone who doesn't want to have a more deeper responses. We know if you achieve a cytogenetic response, or even if you achieve a MMR, the chances of progression is very minimal and very good side effect profile. We have a spectrum seen over the 20 years. Would you like to call up that drug which has been proven itself for last 20 years? The panel does not recommend a first line second generation TKI or change to a second generation TKI for faster deep molecular response, but agrees that change may be considered in selected patients. So I agree with this recommendation. The change is recommended in selected patients. It does not recommend a first line second generation TKI in everyone, and does not recommend a change in everyone. So ELN is like a Bible or Ramayana for us, and this is a new one. There's a recent published in March 2020. I think there's no reason we should be arguing against it. A change from second generation, in fact, there's the other way around. The change from second generation TKI to imatinib can be considered when no DMR is achieved within 5 years. You note this, to avoid the risk of serious cumulative toxicity of second generation TKI. So you can go back to imatinib to avoid cumulative toxicity of second generation TKI. So someone who does not achieve a deep molecular response, you want to avoid a toxicity, you need to be on the first generation rather than on second. So second generation TKIs have a serious cumulative toxicity rather than we have 20 years of imatinib. This is the cumulative incidence of deep molecular response. If you see a CML study 4, the imatinib MR4 was 68% at 5 years. If you see anestin, nilotinib MR4 is 66%. So if you compare the imatinib MR4 versus the nilotinib MR4, why the imatinib in MR4 was lower in anestin, I think we should review that data carefully. There's some problem, but if you see, even with the single dose, the CML study 4, German study over the 10 years is a long-term mature data, which shows you a good deeper response even with the imatinib, which is comparable to the nilotinib MR4. Even a MR4.5, imatinib 53 in CML4 versus nilotinib 4.5 and anestin trial. So I don't see why imatinib doesn't give us a long-term response. Everyone talks about the TFR. This is from ELN 2020, where this is written 80% of the patients will never achieve TFR. For these 20% of the patients, you can put it on the second generation, talk about the TFR. Someone who is 80, someone who is 70, someone who is 65 with the multiple comorbidities, you know you are not talking about TFR. 80% of the patients, even if you try to achieve a ES, will never achieve a TFR. There we are looking for a toxicity. Patient will not mind continuing a drug with a minimal toxicity versus a 20% chance of looking at TFR with a more toxicity. Who should not be on who should not be on second generation TKI. Someone with a low SOCAL score. If you see this NCCN guidelines, low SOCAL score, there is a recommendation one, you can use imatinib. Old age, we are not talking about the TFR, we are talking about the comorbidities, we are talking about the age-related side effects. Patients with the comorbidities should not be on the second generation TKI because there is a cumulative toxicity. We should respect a patient's preference. I will say I have all these 5. I'll discuss with every patient whichever suits him, because all these 4 at least have been recommended as a first line. And as I said in ELN, none of them has been preferred over the other. This diagram shows you, as long as you achieve a less than 10% at 3 months, whether you use imatinib, there is no data to show you if you achieve this 3 months, 10%, even with the imatinib or nilotinib or dasatinib or anyone is better than imatinib. So I strongly feel we can have a patient who achieves an adequate response and can be on imatinib with the same long-term survival and lesser side effects. This is as long as I'm going into the green, this is NCCN guideline. Why should not I be on imatinib rather than on second generation? I don't see any reason someone who is achieving these green zones should not be on imatinib. Why? If he goes into yellow, if he goes into red, we always have an option of changing. This is the low score. You see a category 1 recommendation includes imatinib along with all these 3 these things. Go through the toxicity profile. There is not a single big organ is involved with imatinib. Muscle cramps, fatigue, edema, nausea, diarrhea. No heart, no liver, no kidney, nothing. Nilotinib, the heart, cerebral, vascular. Dasatinib, pleural effusion, pulmonary hypertension, and prolonged QTC. Bosutinib, even there is a pancreatitis. So all these 3 have a difficult to manage side effect profile. Imatinib, all the side effects slowly goes down with the continuation of the drug. This is the Tidal 2, which we were discussing, and it shows you if you start on imatinib, having an adequate response, you can change it and have a similar outcome. I'll just go through the key points. Using imatinib to treat CML first line with a selective nilotinib switching leads to the excellent molecular response and survival. This strategy may be preferable to the universal first line use of more potent, considering a toxicity, efficacy, and economic factor. So this is not me. This is the Adelaide group recommending this trial. How much is our experience with the upfront second generation TKI in India? We are talking about India. How many publications we have? We have a lot of publications with the imatinib. Any big publication on the second generation TKI from India? We will talk about the second generation when we have a more experience. It's just we have got one or two generics recently. That doesn't mean we should be putting everyone on the first line, second upfront TKI. These are my argument. I will say someone who requires a TFR can discuss about the early deeper responses, but someone who is the older age with the comorbidities, we can think of imatinib. It's a safer drug among all these 5. So we have many upfront choices, including imatinib. No, everyone should not be started on second generation TKI. We should take care of the age, goal of the treatment, toxicity profile, and comorbidities should guide us. Thank you.
Wonderful, Dinesh. Thank you very much. You've made a very strong case for not giving up imatinib. And I actually am also convinced, and I'm a supporter of you rather than the second generation for all the patients. Thank you very much. So please stick around for the question answer sessions. So to move on in the program, we're running slightly late. We know that prolonged treatment is required for patients with chronic myeloid leukemia, and about 70 to 80% will require lifelong treatment with these agents. And these are drugs, these are tyrosine kinase inhibitors. In addition to just what we want to do, like inhibit the VCR-ABL, they inhibit lots of other kinases in the body also and produce significant toxicities. So give us an overview of the toxicity, the anticipation of toxicity, and the management of toxicity. I'd like to now involve my very dear friend, Colonel Prakash Chitalkar. Colonel Chitalkar is presently Professor Director and Chief of Medical Oncology at Shri Aurobindo Institute of Medical Sciences in Indore. And Colonel Chitalkar and me, we learned medical oncology together at the same time at the Tata Memorial Hospital almost 3 decades back. So Prakash, the screen is yours.
Thank you, Hemant, for a wonderful introduction. And I'll just take a little while to share my screen. I think.
Kalpesh, can you please help Dr. Prakash leading?
Already shared. I'm surprised. Yeah.
Yes, sir. Minimize this window.
Yeah, this done. Yeah.
Select your presentation. Open your presentation.
Yeah, it is open. Yeah.
And make a slideshow.
Yeah, there we are. And then share, right?
Your screen is free, sir.
Yeah. Now, yeah, correct. How do you share?
So Kalpesh, do you have Dr. Chitalkar's slides with you?
Yes, sir. I will load it.
Kalpesh, you can start it actually.
Yeah. So Kalpesh, you please load the slides, and Prakash, you can tell him to move to the next slide whenever you're ready.
Thank you. My topic is understanding and managing the tyrosine kinase inhibitor toxicities.
Hello.
Here's a disease which we started in 90s treating with busulfan, and came May 2001 when we had Imatinib, and I was in the armed forces that time, and I remember within 6 months the armed forces made Imatinib available to the serving soldiers with chronic myeloid leukemia. And the first 2 to 3 years, we were actually seeing long-term chronic phase patients being put on Imatinib. And predictably, they were actually suffering from a lot of toxicities. And we did not learn about toxicities right in the beginning. So it was a learning process. And today we are in the era of second generation TKIs and long-term cure, functional cure, treatment-free remission, the prospects of treatment-free remission, all that. So today we are in an era where we are going to talk about a curable disease. And so you must know everything about the toxicities. Patient is going to remain on whatever treatment is start almost lifelong. Now the next slide. Kalpesh? Yeah. So these are the 4 studies which actually establish the role of all the 4 drugs that we have: Imatinib, Dasatinib, Nilotinib, and Bosutinib. And you can see that the progression-free survival, extreme right corner of your slides, progression-free survival and overall survival, and all in the ranges of above 83, 85%. So you can imagine that the patient is going to take this treatment for a long period, and so the management of toxicities becomes very, very important. Next slide. This is a cartoon which actually shows the role of various receptors on the tyrosine kinase domains. Platelet-derived growth factor receptor actually causes fluid retention, hypophosphatemia, hypocalcemia, improved glycemic control. Then the EGFR domain itself causes skin rash, diarrhea, mucositis, pneumonitis, venous thromboembolism, and hypomagnesemia. Then the MET actually causes the fluid retention, which is very common in the early days of Imatinib treatment. And the HER2, which also it inhibits, causes the LV dysfunction. And we know that the hair pigmentation, which is so common, the depigmentation, is caused by on account of the inhibition of the c-KIT. Now the next slide. Yeah, so Imatinib toxicity, we got the largest experience, and most frequently reported adverse events are more than 10%, with edema, nausea, vomiting, muscle cramps. And we all know that they actually disappear with continued use. Edema and severe fluid retention is there only for the first couple of weeks and then gradually diminishes. Periorbital edema typically, weight gain, and we need to monitor it closely, but it all disappears over a period of time. Severe congestive cardiac failure and left ventricular ejection fraction reduction is actually quite rare now. The GI perforations, they were described in the initial stages, bullous dermatological reactions. They were all described in the early stages, early stage of the use. And evidently it was on account of the patients with long-term chronic phase being put on Imatinib. Next slide. The Imatinib dose adjustments, well, in chronic phase with absolute neutrophil count, when it reaches less than 1,000 and platelets go below 50,000, we need to hold Imatinib until the ANC goes back to 1,500 and the platelets go above 75,000 and resume the Imatinib at about 400 milligrams. If the recurrence again occurs within a couple of weeks and the ANC goes down below 1,000 and platelets below 50, again hold it and keep it until the ANC rises above and the platelets go above 75, and then reduce the dose to 300 milligrams. I know most of the patients across India are, many of them, all of us have small number of patients who always do very well with 300 milligram imatinib. Accelerated phase of blast crisis is a little different boil game, where you might like to see if the ANC goes below 500 and the platelets are below 10,000. Then, if cytopenias are unrelated to the disease, reduce the dose to 400. Because in the early stages of blastic phase, this neutropenia and cytopenias will be because of unrelated to the. It'll probably be, so we need to reduce the dose. If the cytopenias persist for more than 2 weeks, then you reduce it further to 300. If cytopenias persist for more than 4 weeks, stop imatinib until the ANC again goes above 1,000 and the platelets are above 20,000. Then you might start with a modest dose of 300. Growth factors, of course, can be used when patient is has a resistant neutropenia who keeps requiring reduction of doses. And the next slide. The renal impairment, we all know the moderate renal impairment, creatinine clearance in the range of 20 to 40. You should reduce the dose of imatinib to 50% of the original dose. And for patient with moderate renal impairment, doses greater than 400 milligram are never recommended. And that would occur in a blastic phase sometimes. The hepatotoxicity, if bilirubin more than 3 times upper limit of normal or transaminase is more than 5 times upper limit of normal, withhold the imatinib until the bilirubin returns to less than 1.5 and transaminase less than 2.5 upper limit of normal. The treatment may be continued at a reduced daily dose of 400 to 300 or 600 to 400. Cautiously, the transaminases are in the slightly elevated range. Next slide. Dasatinib, that's a second generation TKI. The most frequent serious adverse events continue to be pleural effusion, hemorrhage, congestive cardiac failure, and pyrexia. We know that they also are now uncommon, especially since we've the initial phases of the use, we are giving doses as high as 140. Now we give lesser doses, 70 milligrams, 50 milligrams, 100 milligrams. And so now these side effects have become much less. Now the recent data suggests that a pleural effusion is as little as 11%, GI bleeds, febrile neutropenia, diarrhea, all are in the range of single digits. And so now the toxicity has become very, very manageable. Myelosuppression does occur sometimes with dasatinib, and you need to require more frequent counts and then gradually monitor it, and it's very, very manageable. Generally reversible and usually manageable by withholding the drug temporarily. Next slide. Well, the fluid retention can be, if you have a pleural effusion also and a fluid retention, then you need to repeat the chest x-rays again and again. Manage with supportive care measures like diuretics and short courses of steroids, say 20 milligram per day or 40 milligram maximum for 3 or 5 days. And then a severe pleural effusion may require thoracentesis and some oxygen therapy. QT prolongation is known, although less common than the other second generation TKIs like nilotinib. But the caution in patients with hypokalemia and hypomagnesemia and antiarrhythmic medications may be required. Congestive cardiac failure, left ventricular dysfunction, myocardial infarctions are known, less common, but yes. Pulmonary arterial hypertension, yes. And if it actually occurs, then we need to permanently discontinue dasatinib. And laboratory abnormalities, grade 3 to 4 elevations of transaminase or bilirubin with hypokalemia are reported, and most recover the oral calcium supplement, and it actually doesn't require discontinuation of dasatinib. On the next slide. Dose adjustments, well, again, the similar algorithms are used, and then resume the dasatinib, again starting dose, usually within 7 days or 10 days. If the platelet counts go below 25,000, ANC goes below 500, then hold the drug until it again goes above 1,000 and platelets are above 50,000. And you may reduce the dose to even as little as 50 milligrams and then continue at that level until the cytopenias improve. Further reduce the dose to 50 milligram if duly diagnosed patients, or even discontinue if it occurs again and again. Accelerated phase of blast crisis, cytopenias, if unrelated disease, hold dasatinib until the ANC rises and resume at the original dose. Where if it recurs again, then you may reduce the dose. And then if cytopenias are related to the leukemia, consider dose escalation to actually 140. That is a mistake, that should be up to 140. And the next slide. Nilotinib toxicity, well, rash, pruritus, headache, nausea, fatigue, they are common. And we do encounter them very, very frequently with nilotinib use. And since I treat teenagers and young adults, we have at least half a dozen patients with chronic myeloid leukemia below the age of 30. And we've had ventured to actually give them nilotinib upfront because 2 of them had chronic myeloid leukemia with blast crisis at presentation. And I'm glad to say that although it was experimental use, or we have had at least 5 of them are doing extremely well with no toxicities, and all of them actually major molecular response. So myelosuppression, well, does occur, but again in the first 4 to 8 weeks of therapy, and then they gradually it actually disappears with continuous use. QT prolongations are known, and 7 days to 15 days after initiation, we monitored them and we continued the nilotinib, and we did not come to grief. We did not have to discontinue the nilotinib. Elevated serum lipase is known much more commonly with ponatinib, but also with nilotinib. And lipase elevations are accompanied by abdominal symptoms, cramps, sometimes distension of abdomen, and it requires interruption of dosage and actually carefully monitoring the patient for pancreatitis. We do not have experience of this, but it's given in the guidelines. Can cause hypophosphatemia, hypokalemia, hyperkalemia, and so on, and even low calcium and low sodium. Correcting electrolyte abnormalities prior to initiating therapy seems to be the way. Next slide, please. The dose adjustments, well, the QTC duration of 480 milliseconds seems to be the cutoff. Withholding Tasigna and analyzing the potassium, magnesium seems to be the key. Resume within 2 weeks at prior dose if the QTC returns to less than 450 milliseconds and to within 20 milliseconds of the baseline. If, however, if it is between 450 and 480 for 2 weeks, then reduce the dose to 400 milligram once daily. If following the dose reduction to 400 milligram once daily, the QTC returns to more than 480, Tasigna should be discontinued altogether. And ECG should be repeated more than every 7 days at any dose adjustment. Neutropenia and thrombocytopenia do occur, and if they go below 1000 and below 50%, then nilotinib and monitoring requires resuming after 2 weeks until the counts recover. If the blood counts remain low for more than 2 weeks, reduce the dose to 400 milligram once daily. Elevated lipase and amylase, hold nilotinib. Reduce nilotinib at 400 milligram once daily if serum levels return to less than grade 1. May I have the next slide?
Prakash, can you wind up last 1 minute, please? Thank you.
Yeah, very quickly. The bosutinib, well, GI toxicities and hepatic enzyme elevations are the most likely side effects, and they can change, they can improve with careful monitoring and reducing the dose. May I have the next slide? Here are the adjustments. If you have a transaminase raise up to 2.5, resume the dose to 400 milligram once daily. Thereafter, if recovery takes longer than 4 weeks, discontinue bosutinib. If transaminase level more than 3 times upper limit of normal and the bilirubin also is raised, discontinue bosutinib. For diarrhea, you need to monitor closely and then resume at 400 milligram once daily. By the next slide. So ponatinib is new, and we all know the venous thromboembolism and arterial thromboembolism has been a problem, and we do not have experience of it. But apparently, congestive cardiac failure and thromboembolism have precluded the use. It is getting re-approved, and we do not have experience of it as yet. And the next slide. The dose adjustment is supposed to be between 45 milligram down to 30 milligram, then 15 milligram, then go up again. Next slide. So this is a summary slide which shows that Imatinib, how do you monitor the long-term safeties, hematological toxicity. All this has been already discussed. We'll not go to that. Next slide. So there I am, and we'll be open to questions during before the panel discussion. Thank you very much.
Thank you very much, Colonel Chitalkar, for a nice overview of all the toxicities. I think it's very, very important for us to know these toxicities, to anticipate them and to manage them, because our patients of CML, they will require, most of them, treatment for several years and sometimes for lifelong. So now we come to the most exciting development on the CML front, treatment-free remission. And this is a concept which has, from a concept, it has moved to science now. And we know that for a small number of our patients, maybe 15 or 20%, a cure of the disease, meaning control of the disease in deep molecular remission without the TKI is possible. And to tell us more details about this treatment-free remission, we have Dr. Hari Menon. Dr. Hari Menon was previously the head of hematology at Tata Memorial Cancer Center before he decided to move home to Bangalore, and is presently a senior consultant hematology and medical oncology at the Site Care hospitals in Bangalore. So Hari, you have 10 minutes. Please try and finish in time. We're running a little late. Thank you.
Thank you. Thank you, sir. And I hope the screen is shared. Okay. Is my screen shared? Hello?
See
Yes,
your
sir.
presentation, Hari. We can see like your desktop, I think.
Yeah, I mean, is my presentation shared? Because I can see my presentation here. I've shared it, but I just...
No, we can't see your presentation. Sorry. You'll have to maybe try one more time or maybe have...
Okay, has it come
Yes,
now?
yes,
Yeah,
sir.
that's fine now. Please go ahead.
Okay. Okay, thank you, sir, for the kind introduction. It's probably one of the most exciting aspects of CML that we are talking about today. And the concept of treatment-free remission is something that is not a new concept, I would say. Historically, there has been a high percentage of patients with CML in chronic phase undergoing stem cell transplant who has remained treatment-free following transplant. And we do understand that that has been way back in 2007 and then again demonstrated in 2010. And especially those patients who, during the interferon era, who underwent transplant, and those patients who were transplanted while in the era of the TKIs also had very good durable responses. So again, we have this concept of the operational cure that has come into the picture of CML, and TFR achieved without transplant in a subset of patients receiving interferon alpha was a very well documented fact. And patients with sustained undetectable BCR-ABL at 2 years on interferon alpha remain disease-free at a median follow-up of 8 years. But this happened in about 20% of the patients, and this was published in this paper by Hagop Kantarjian, who probably the MD has got the maximum experience of using interferon, and they clearly demonstrated that this was possible in CML. So what did transplant interferon data suggest to us? And it suggested a few points: that it is important to achieve a deep molecular responses, which is what was seen in a common factor in whether the patient underwent transplant or whether the patient received interferon. And it is important to also sustain those responses over a period of time. We also realized that there were patients who were in the early phases and the early phases of the disease who had a better chance of attaining those responses. And this was particularly true for those patients who went on to undergo transplant in the early phase of the disease. And lastly, the sustained deep molecular responses could translate into operational cure, and this was something that was seen with the interferon data. So what are the thoughts on TFR in the era of TKI? So we do understand that tyrosine kinase inhibitors induce rapid induction of complete cytogenetic responses, the highest proportion that one came across till the TKIs came into the picture, and the second generation also came into the picture. A higher proportion of patients going into deeper molecular responses were also noted, and there was also clearly that the ongoing deepening responses were sustained when you were compliant with the treatment, and it was a matter of time dependent. It was time dependent that the longer you had exposure to a tyrosine kinase inhibitor, and the better was your chance to sustain those responses. But of course, we do understand that over a long term, as my previous speakers have spoken to, and Dr. Chitalkar spoke, the adverse events that have been associated with TKIs is not something that can be neglected. And lastly, the economic toxicity that comes through with the prolonged use of TKI, and also something which we always consider, which is impairment in quality of life in many of these patients. We tend to ignore this aspect in the light of the fantastic responses in terms of control of the disease. But when we actually look at the quality of life, there is definitely an impairment. So the question is, can all patients actually adopt the strategy of treatment-free remission? And if not, who are the ones who can be advised to adopt the strategy? So we do understand from the various studies, including the IRIS study, that there were people who were achieving molecular responses over a period of time. And we know that both from the NSTND study and the Deceasing study, and also the CML4 study, where from the German group, where they use higher doses of Imatinib, the stronger the TKI and higher the dose of imatinib, better the chances of achieving MR 4.5 over a time period. And the IRIS study clearly demonstrated that these responses tend to occur continue to occur even beyond the time point of 5 years. So therefore, the question that emerges is, can we persevere with imatinib itself with the objective of treatment-free remission? And is the second generation TKI going to do a better job in achieving this objective? And are there prognostic factors to start with which can tell us who is going to achieve that response? So the first time 10 years ago, which was published, was the STIM study, which looked at imatinib in patients who had sustained responses and achieved undetectable BCR radial transcripts. And in those patients, and in the long-term follow-up, what came about was that the probability of relapse-free survival was about 43% at 6 months, and it dropped down to about 38% at the end of 24 months. And the probability of treatment-free survival at 6 months was about 59%, and at 24 months, about 41%. But this was a very, very defined population who consistently had an undetectable BCR-ABL transcript over at least 3-year period. The STEAM study also demonstrated that those patients with a high SOCAL score did worse than those patients with a low SOCAL risk score. And so thereby saying that this particularly the low SOCAL risk score group were the people who needed to be targeted mainly for TFR. The TWISTER study looked into the objective of the study was to demonstrate sustained treatment-free remission in CML patients stopping imatinib therapy after stable, undetectable, minimal residual disease. And there was opportunity to reintroduce imatinib also at the time of molecular relapse. So quantitative PCR every month in the year 1, every 2 months in the first 2 years, and every three months in the year 3 was considered. So all patients who had achieved undetectable MRD greater than 24 months were included in the study. Much like the STIM study, this also demonstrated close to a 42.7% TFR at the end of 1 year. So all patients who relapsed, importantly, all patients were sensitive to imatinib after treatment, and 8 patients who lost MMR regained responses after a median duration of treatment of 2 months. So one of the largest studies which looked into this was a Euroski study, which included almost 756 patients. And what, in a nutshell, what the Euroski study showed was 61% were free of were in MR at 6 months, and 55% were free of disease at 12 months. So in patients receiving imatinib, longer duration of imatinib therapy contributed to better chances of achieving the goal of TFR, deeper responses, and the minimum of sustaining a molecular response of MR4 duration was also important. And there were some patients who were on interferon in this group, and longer duration of pretreatment with interferon also contributed to better outcome in these patients. Since then, there have been several studies, which is a series of studies which included the first generation, the second generation medications, mainly include dasatinib and nilotinib. And these are a series just for us to understand. There was a whole load of studies which came about. But what do we conclude from these 3 main studies as far as TFR is concerned is achieving deeper molecular response is critical, sustaining that response for sufficient duration is critical, longer duration of TKI intake will favor a better outcome. There was some conflicting data as far as SOCAL risk score is concerned, but one can hope for a TFR if selection criteria adhere to the tune of about 40 to 50% across the board. So this was, can second generation improve the outcomes? This was the STOP second generation TKI study. 24 patients lost MMR after a median follow-up of 4 months. The treatment-free survival probability without losing the major molecular response was about 61%. And all but one patient who lost MMR achieved regained their responses on reinitiation of therapy. So again, approximately about 41.7% versus 67% prior history of suboptimal response was a contributing factor to not achieving a TFR. So that comes us to what are the predictive factors for maintaining TFR? So if you look at some of the major studies, the STIM study demonstrated that low risk SOCAL and a high natural killer cell count contributed to better chances of achieving TFR. The TWISTER study demonstrated a deeper unrecordable MRD of less than 9 months, duration of interferon treatment greater than 12 months, and achievement of unrecordable MRD of less than 9 months contributed to better outcomes. The KIDS study, which looked at dasatinib, looked at the digital PCR, which is a more sensitive tool at screening, and if your digital PCR values were less than 0.468, they had a better chance of achieving a TFR. The Euroski study again showed the importance of natural killer cell activity in contributing to TFR, and the DARDI study, that is dasatinib discontinuation study, demonstrated that any history of imatinib resistance in the past contributed to lesser chance of TFR. And again, as the Euroski and the STIM study, natural killer cell count contributed to better outcome, higher natural killer cell count. So this is just a summary, a table, which is a busy slide. I will not go through this too much, but just got to say that whatever I highlighted in the previous slide were some of the things that emerged in terms of determining who are the patients who will go on to have a sustained TFR. So so whom do we recommend for going in for TFR? So these are the European guidelines and the NCCN guidelines, and I sort of, in terms of its simplicity, I like Tim Hughes and the Adelaide guidelines, which clearly says that we need to have an institutional criteria for this in terms of who we have to choose. We should have a stringent molecular testing which can be reproducible. SOCAL risk score, which is low, is a better chance. All those are in green are the people who can go in for a TFR. The BCR-ABL transcript, there is some documentation that the E14A2 have a better chance. The type of CML in chronic phase is important. You need to look at the duration of TKI therapy, the depth of molecular response, and the duration of that depth of molecular response also. The longer you have the deeper response, the better chances of achieving that kind of a remission. So in a nutshell, as far as who's going to benefit, we should look at the availability of high quality, internationally standard, accurate, sensitive RQ-PCR laboratory, rapid turnover time of the RQ-PCR test within 4 weeks, capacity to provide an RQ-PCR test every 4 to 6 weeks when required, and structured follow-up established to enable a rapid intervention if BCR-ABL is rising. So I will conclude that discontinuation of TKI in CML patients with sustained DMR is feasible and safe. On an average, 40 to 60% of the patient would still relapse after achieving a TFR, and molecular relapses typically occur within 6 months. Those relapses are lesser in the next 6 months, and the chances of having a relapse if after 12 months of cessation therapy is exponentially lower. So most patients who regain responses when TKI treatment is reinitiated is consistently has been reproduced. And although late relapses are rare, they do occur, and which means that continuous monitoring in these patients is mandatory. So attempting a second generation, second TKI discontinuation after molecular recurrence is also still possible. But again, you need to go through those time frames of at least sustaining the deep responses for 2 to 3 years And we can expect, even in these patients, about 30% of them to actually go into a state of TFR. So with that, I will conclude my talk, and it's back to you, sir.
Thank you very much, Hari, for comprehensive coverage of the TFR scenario in our country and in the world. And I think that is something which excites us most. When we started oncology 2 decades back, everybody was doomed to take treatment for the whole of their life. But now at least 20 to 25% patients can stop the treatment. So my apologies to my panelists. We are running about 20 odd minutes late. Like some technical issues and the very stature and the wonderful presentations which the speakers made. I didn't have the heart to interrupt them for 1 or 2 minutes. So please bear with us. I hope you enjoyed the discussions. So in the next 20 or 25 odd minutes, we will see if we can cover a few cases and thresh out some practical points for our audience. And I'm told that there are about 300 students and faculty members and practitioners listening to our webinar. So let's see if we can give them some practical tips as to manage a CML on a day-to-day basis. So can I share my screen, guys?
Yes, sir.
Okay, can you see my screen?
Yes, sir.
Okay.
Yeah.
So let me introduce my panelists to you. Dr. Lalit Mohan Sharma is a very dear friend of mine from Jaipur. We do lots of conferences and lots of projects together. Lalit is senior consultant, medical and pediatric oncologist at the Bhagwan Mahavir Cancer Hospital in Jaipur. We have Dr. Sandeep Shah from Ahmedabad. Sandeep has figured in a lot of CML studies. He has several publications on CML to his credit. He is presently senior hemato-oncologist and medical oncologist at Sterling Cancer Hospital in Ahmedabad. We have Dr. Shekhar Patil, senior medical oncologist at HCG Cancer Center in Bangalore. Dr. Samir Tulpure from Bombay, senior consultant and clinical hematologist at the very well-known Kokilaben Dhirubhai Ambani Hospital in Mumbai. I think Dr. Somia from Calcutta will join us subsequently. Dr. Rahul Bhargav, my dear friend from Delhi. He is director and head of hematology and hemato-oncology, and he's a stem cell transplant expert par excellence. He presently works at the Fortis Research Institute in Gurgaon. Dr. Shirish Alukar. Alukar is a very dear friend of mine. Some 30 odd years back, we trained in medical oncology in Tata Hospital together. And I have some very, very fond memories of Shirish and myself on the 10th floor of Tata Hospital where we used to stay. He is senior consultant at the Apollo CBCC Hospital at Ahmedabad. And last but not the least, Dr. Sada Shivdu, additional professor and head of the Department of Medical Oncology at the prestigious Nidam Institute of Medical Sciences in Hyderabad. And there are the maximum number of CML publications from our country are from Dr. Sada's institute. So I hope my panelists will permit my gray hair and my age to address them by their first name. And let's quickly start the panel discussion. So our first case is a 31-year-old MD in pediatrics. He is senior resident in pediatrics. This is an actual case. Came in April of 2016 with high-grade fever. He had a CBC done which showed high counts and a small spleen, BCR-ABL of 81%, low focal risk diagnosis. We counseled him for a second-generation TKI, but he opted for Imatinib, so he was started on Imatinib. He had an excellent and optimal hematological and molecular response. He is presently on 400 milligrams of Imatinib. Absolutely no side effects other than the fact that he's become several shades fairer, and he's had a deep molecular response. So this is his molecular response chart. I don't have a BCR result after this, but you can see that in just about a year and a half's time, he had a deep molecular response. Now, fortunately, this young man got selected in the Rajasthan Public Service Commission to be assistant professor in pediatrics. As is customary, all people joining government service have to go through this medical board. And now you are the convener of this medical board. And my question to you is, would you recommend to the government as convener of the medical board that this young man is fit and approved for government service, or that he has chronic myeloid leukemia which can come back at any time, and he is not fit to join government service because this is a high risk situation? And you know, your neck is on the line, because if you approve this gentleman and that he is disease free and he has a relapse, then you are going to be in serious trouble and there might be an inquiry instituted against you. So let me ask this question to Dr. Rahul Bhargav. Rahul, what would you do in a situation like this? You are the chief of the medical board. Would you okay this man, this
Yes,
young
sir.
man? Yeah, go ahead.
So we will clear the person saying patient is fit, because the whole thing is at this present moment of time, he is in CML CP with a deep molecular response. Though the response is 0.0197, still not into MR 4.5, nearing towards MR 4. But the whole idea is his chances of achieving an MR 4.5 and thereby his chances of getting converted into AP or BCs practically zero. So I would not bother about it, and I will say he is fit.
Very good. Dr. Sada, you work in a government hospital, and this might be a usual, maybe not a usual situation, but this situation can arise for you on Monday morning. What would you do?
I think what Bhargav said is correct, sir. Because
Sada, can you just speak a little loud? Your audio is not very clear.
Yes, sir. Hello, is it okay, sir?
Yeah, yeah. Speak as loud as you, as loud as you.
Dr. Bhargav said, I think it's right, sir. I think this person is fit to any government job because this is under control. Nowadays, I think the longevity of the CML patient is as normal as normal person. Okay, so if we have something good monitoring, so there is no doubt in that. Only thing is what you said is something like the cost of the treatment in the future. Most of the government people may say something is cost of treatment is borne by the government. I think like any diabetes and hypertension now, I think all these disorders are like chronic disorders. So we can't just make him unfit for the job. So definitely we can do the fitness and we can mention that one. We can live longer. At the future, we can go for TFR studies out there. I think we can convince any government official based on this. So I am saying fit.
Very good. So this actually situation happened with me. Of course, I will not share the identity of the gentleman, but I also did what both my panelists are saying. I declared this patient fit. I'm very happy to tell you that he got selected and is now a faculty in one of our medical college hospitals. Any one of my panel have any comment on this? Anybody? One quick comment, then we can move on to the next case, or maybe a little bit of theory on this and then the next case.
So Dr. Hemant, the only thing Dinesh and everybody has spoken, the role of TFR and so on and so forth. But my opinion of choosing a medication is of a second line TKI is our ability to prevent even one person going into blast crisis. The data is very clear. People who achieve MMR still has got
Rahul, pardon me for interrupting. We have a case which will discuss that. Maybe I will take your opinion that time. So, you know, there have been at least two publications, one from the JNCI and one the JCO, in which it is very clear that the survival of patients, whether they are males or females, whether they are whatever age group they are, 55 years, 65 years, is now close to the survival of the people in the general population who are not patients. So I think with expert management, we have been able to do this, which has been a huge advance in the treatment of chronic myeloid leukemia. And the mortality now is driven by the comorbidities which the patient has and not by the chronic myeloid leukemia. So let's come to case number 2. We have a 38-year-old farmer, 4-month history, large spleen, high counts, high platelets, few blasts, raised basophils, raised eosinophils, and the standard CML marrow, Philadelphia chromosome positive, BCR able positive. So final diagnosis of CML chronic phase, high Sukal risk, and intermediate ELTS risk. So ladies and gentlemen, I'd like to emphasize to you that in addition to the Sukal, we should now also get into the habit of at diagnosis calculating the ELTS score, because in the TKI era, this is the score which gives you the maximum survival information. So now my question first to Dr. Sandeep Shah is that in addition to usual hydration, allopurinol, hydroxyurea, what treatment would you start on this patient? Imatinib standard dose, imatinib high dose, dasatinib standard dose, low dose, nilotinib, bosutinib. Sandeep.
I think this patient was diagnosed in 2014 or 16. So
sorry, Sandeep, can you speak up? You're a little loud.
This patient was diagnosed in 2014 or 16, I think.
Yeah.
So that time, generic dasatinib was not available. So probably I will start him with imatinib 400 milligram standard dose and see the early molecular response at 3 months. And then I will decide further treatment.
Okay, so Lalit, you understood the case. How would you approach this patient today? Suppose this patient comes to you today, now,
yes.
How would you approach this patient?
Sir, I'll be having preference for the second generation TKI and preferably dasatinib in modern era, because the patient has got high Sokal score, so we need to hit hard. And second thing, we need to be having a target of achieving TFR, at least a possibility in our mind. So
okay.
I'll be going for.
And your choice of drug with the second generation TKI is all the agents, at least the 3 agents, dasatinib, nilotinib, and bosutinib are available to you.
Yes.
What would you choose?
Dasatinib because of the convenience, sir. Otherwise, we have used more of nilotinib because of the various support programs by the company.
So Lalit would choose dasatinib because it's an MCure program and they have a generic dasatinib. Is that right, Lalit?
No, I think that's not right, sir. It's convenience as well.
Yeah, I completely understand that. That was a below the belt question.
Yes.
Shekhar, would you agree with Lalit or do you have a different opinion? Shekhar, are you there? Can somebody unmute Shekhar, please? Dr. Shekhar Patil, are you there? Kalpesh, is Dr. Shekhar online?
Yes, sir. He's online.
Is he unmuted? Shekhar, can you hear me?
Hello.
Yeah. Hello? Can you speak up, please? We can't hear you. I can't hear you.
Hello. Are you hearing me, sir?
Yeah, we can hear you, but please speak a little loudly.
Yeah, basically, I agree. Today, because of the availability of the generic dasatinib, I would consider that one, because with imatinib with 400 or 600, the chances of achieving deep molecular responses or long-term remissions with high Sokal score are less. So I would definitely consider dasatinib today with availability in the generic form.
Do you have a different opinion? Like you work in a hospital where they're all rich patients, there are no economic considerations. Samir?
Sir, given the hospital's name, I think it's a misconception that everybody can afford treatment here. So I think to begin with, I would agree with what the panelist is saying, that he's a young person, high Sokal score. And as Dr. Bhargav as well said, that the aim should be to prevent going into a blast crisis. So I think I would prefer a second generation here. Now, between dasatinib and nilotinib, having used both of them, the incidence of pleural effusions and things, at least when I've used, are slightly higher requiring chopping, changing of medications. So if someone can afford both, nilotinib is what, Desiccina is what I would probably go for, because I haven't changed them too much.
Okay.
I think Rahul wants to say something towards this.
Yeah, Rahul, very quick comment, please.
So, Dr. Samir, I completely agree with dasatinib, with nilotinib. That is also troublesome. It is not also such a easy drug. You tend to develop diabetes. So, young patient has developed diabetes.
Yeah.
QTC prolongation, and so
Rahul, your audio is
on
not
nilotinib
good.
also, one of our patient has developed heart failure. So I think cities often. So can you hear me now?
Yes. Yeah.
You have a
Yes, certainly there's a bit of echoing, and then you go off. I think that's what's happening.
Yeah.
So
Okay,
can
Rahul,
you
your point is well taken. All the drugs have some
Yeah.
toxicities, and we need to very carefully look at that, as Colonel Chitalkar said. And this, I think,
it's just the inconvenience of a twice a day tablet with nilotinib. That's all.
and taking it on an empty stomach, sometimes it can be an issue with some people, right? So this is like the 5-year dasatinib data. You can see that 5 years, both with respect to MMR and MR 4.5, dasatinib is significantly better. Similar with 10-year nilotinib, the major molecular response rates are significantly better. And this is with the before trial bosutinib, again, exactly the same findings, higher MMR rates, higher MR 4.5 rates, and higher MR4 rates. And this, again, I think a slide was shown to you earlier. You can see nilotinib and dasatinib, the significant gain in complete cytogenetic responses, major molecular responses at 5 years, deep molecular responses at 5 years, both with nilotinib and dasatinib, but no difference in overall survival. And so you have a choice of drugs, and I think the choice which drug, which imatinib or which second generation TKI you start will also depend on how fit your patient is and what comorbidities the patient has, even in the first line, not only in the second line.
But Hemant, can you just
Go ahead.
Can you take the voting of the panelists? If price of the dasatinib and nilotinib is same, what is their first choice, dasatinib or nilotinib?
Sandeep will do it when we meet face to face. This is difficult to do a polling on a Zoom meeting.
So Dr. Sandeep Shah, the answer is simple. Dasatinib vocal for local.
So that is why I'm telling you prices are same of nilotinib and dasatinib.
Still dasatinib, sir. Once a day tablet is easier.
Yeah. Okay, both of them have advantages and disadvantages. So, Shirish, this question is going to go. You will have to answer this question. So, see the case carefully. We have a 28-year-old female, one child, and is desirous of more children, like standard high-risk CML, final diagnosis CML, CP, high focal risk. Now, here is the question. She was started on dasatinib as per recommendations of Rahul, had a quick hematological response and a good optimal molecular response with minimal toxicity. 6 months from today, she had almost a major molecular response. She is on 8 weekly follow-up. And now when she comes to you yesterday, she tells you that her pregnancy urine strip is positive and her last menstrual period was 6 weeks back. So she has been exposed to a second generation TKI for about 4 or 6 weeks into the first trimester of pregnancy. Now, Shirish, what would be your advice for this patient? Should she continue pregnancy and also continue the TKI? Should she continue pregnancy, stop the TKI? Would you advise her a medical termination of pregnancy and after that is done, continue dasatinib? Or would you choose something other than these 3 options? Shirish.
Yeah, thanks, Hemant. Firstly, I was surprised where you got my photograph from. I didn't know this photo existed at all.
So you can either fight or thank the organizers for that.
Okay.
They are in
Okay.
Ahmedabad only. You can beat them up.
Okay, yeah, sure. Okay, firstly, I'd like to say I don't deal much of with CML, mainly into solid tumors. But yes, in this case, I would ask the patient to, if she is not so much for, when she wants to continue pregnancy, right? But if she has, if she has other issues,
she has one child, but she is desirous of one more child.
I would still counsel her that you better stop, stop dasatinib, or if she wants to continue pregnancy, just to stop dasatinib. There's no other option then. Or the best option would be to do a combination of pregnancy and continue dasatinib if the disease is a priority.
Okay. So fair enough. Your option of choice would be option 3. You would advise a medical termination of pregnancy, and once you're done with that, then you start the dasatinib, right?
Right.
So I have Soumya online also. So Dr. Soumya is a consultant, senior consultant hematologist at Apollo Hospital in Kolkata. Dr. Soumya, what would you do? What of the 4 options you see on your screen would you advise for this patient?
Thanks, Dr. Malhotra. Basically, there has been case reports where pregnancy has successfully continued in spite of a patient being on TKI inhibitor. For example, there has been case reports of successful conclusion of pregnancy on patients with Imatinib. Now, the issue is here the child has been exposed early in the first trimester, and the lady is desirous of having another baby. I think that probably medical termination of pregnancy is too harsh course to follow. I will definitely discontinue dasatinib, and I will probably opt for some other option which won't be that harmful for the baby. For example, if interferon, alpha interferon is available, I will probably prescribe alpha interferon. Let the pregnancy continue, deliver the baby, and once the baby has been successfully delivered, then probably return to dasatinib. That would be my option.
Okay, so anyone of let me ask Dr. Lalit. Lalit, what would you do?
Yes, sir. Yes, sir. My option will be number 3, sir, MTP, which I will advise and then discuss with the patient. But my advice will be to go for MTP and then continue dasatinib, and for subsequent pregnancy, we will ask her to do it in a planned way so that we can plan to stop the TKI before pregnancy.
Okay, so Shekhar, you work in a very fancy private hospital in Bangalore where you have lots and lots of rich, very aware, very literate patients who will not hesitate to take you to court in a minute. What would you advise?
Definitely, I would advise for MTP, and I will continue the dasatinib, because here the risk of some amount of congenital anomalies are higher in the first trimester, which is exposed already 6 weeks are over. So I would definitely not take a risk of continuing the pregnancy at all.
Shekhar, can you speak up? We can barely hear you. A little louder, please, or a mic closer to you.
I would continue with I would stop the dasatinib.
People, we can't hear you. Can you speak up, please? I know you're a very soft-spoken gentleman, but we have to hear you.
Can you hear, sir, now?
We can barely hear you.
I think some problem is the mic connecting there. I am very, very close to the thing, sir.
Now it is much better. I don't know what happened. It is much better.
I will advise for an MTP and continue the dasatinib. I don't want to take any risk of having a congenital anomaly in the child under whatever, except because she can have one more child later on, and she is on dasatinib. After 2-3 years, we can stop and go for one more conception. We can respect her views, but not with this continuing this particular pregnancy. I don't advise her.
Okay, so any other opinion? Very, very briefly, because we'll do a 4th case and then we'll go to the question answers. Anybody has an opinion?
Yeah, I think I have some. So we have something data on Imatinib. First trimester, most of them they have used.
Thoda sa jor se we can. I mean, we want everyone to hear you.
Hello, sir.
Yeah.
Yeah. Yeah. One thing is with the Imatinib, we have a clear-cut data. Even the first trimester with 400 mg, none of them they develop any complications. We presented data in ASCO. And the desertib also, they have some data, but still the patient, we have to explain pros and cons of this continuation of pregnancy. If nowadays we have the good imaging modalities, we can find out the congenital anomalies. So once we have to explain pros and cons, we can continue the pregnancy and first stop the desertib. But we should be very clear in that. We have to explain in detail. Then only we can take the decision. The decision should be taken by the patient, not the doctor.
Okay, so I'll tell you my opinion, what I would do in a situation like this. The chances of adverse fetal effect in normal pregnancies, which are not exposed to any teratogenic drug, is 1 to 2%. And with TKIs, I agree with Sada that the most of the data is with imatinib, but also with second generation TKIs, this adverse fetal malformation incidence goes to 10 to 15%. The majority of these adverse fetal outcomes are stillbirths. So if there is a stillbirth, of course, it's a major psychological trauma to the patient and the family. But the remaining 5 to 10% of fetal abnormalities, which the patient and the family has to live for their whole life. And of course, this decision is the patient's decision and the family's decision. And there is a 80 to 90% chance that you can have a normal fetus also. But the unequivocal recommendation from our side should be an MTP. And if the patient chooses not to have an MTP, that should be very, very clearly documented in your case file. So, agar khuda na khasta, there is a fetal malformation, then at least you are legally safe. And I think what Lalita said is absolutely appropriate in this patient. We would try and discontinue this pregnancy and not discontinue the TKI for very long. And then subsequently, after 1 or 2 or 3 years, then use the TFR principles which Hari told us, and then do a planned pregnancy. Okay, so I'll go to the last case quickly. Why is my slide not moving? Okay, so this is a 48-year-old banker. The only thing different in this patient from our usual patients is that he had chronic renal failure. His urea is 98, his creatinine is 3.2, and the creatinine clearance is 28. And the ultrasound shows bilateral contracted kidney, with loss of cortical or medullary dysfunction, a distinction suggestive of chronic renal disease. So you have a final diagnosis of CML-CP, high focal risk, with CRF and a creatinine clearance of 28 ml per minute. Now let me start with Rahul. Rahul, how would you treat this patient? Which TKI would you give? Would you give standard dose? Would you give reduced dose? Which TKI you would not give? Rahul?
So if we have a renal dysfunction, is it audible?
Yeah, we can hear you. Go ahead, please.
So if it is a renal dysfunction, then the dose of imatinib has to be reduced.
Okay. And what about the second generation TKIs?
So again, in a second generation TKI, not much of a interaction with the renal dysfunction. It is only with imatinib which has to be done. I'm not sure about dasatinib, but for dasatinib and nilotinib for sure, we can give the full dose.
Anybody has any other opinion on this? I had a patient a few weeks back like this, and I could not from my existing knowledge decide what to do with that patient. So I looked at the product information of all the 4 drugs. I'll show you that in the subsequent slide. Does anyone of my panel has an input on this? Samir, what would you do? Samir, are you there? Hello, Samir. Sandeep, you are the CML expert. What would you do? Dr. Sandeep Shah?
To be on safer side, I will start with dasatinib 50 milligram, because now 50 milligram data is also available, and to be on safer side with in chronic renal failure patients, I will start with dasatinib 50 milligram.
Okay, so in the interest of time, I will go ahead. So this is the product information material which I am showing you. Imatinib is not excreted by the kidneys. Patient with mild to moderate renal dysfunction can be given low dose imatinib, low dose meaning 400 milligrams, but with utmost caution and close observation. Patients who have severe renal dysfunction, creatinine clearance of less than 20, or who are on hemodialysis should not be given imatinib. Now, nilotinib and dasatinib clinical studies have not been performed in patients with impaired renal function, and clinical trials with these two agents excluded patients who had a serum creatinine of more than 1.5 times the upper limit of normal. And even though the metabolites of these agents are not majorly excreted through the kidney, we do not have data on using these agents in patients with renal failure. So my takeover here is that this is what the patient also gets to read. And if there is a worsening of the renal failure with one of these agents, even with reduced dose, at the moment it is difficult to recommend them. So my suggestion would be that you go with 400 milligrams of imatinib and monitor it very carefully. Now, contrarily, for bosutinib, the product information says that patients who have moderate renal failure can be given 300 milligrams of bosutinib, of course, with careful monitoring. And even patients with severe renal failure, creatinine clearance of less than 20, they can be started on 20 milligrams bosutinib with careful monitoring. So this is just some information for you to digest. Imatinib, mild and moderate renal failure, 400 milligrams per day with caution. Severe renal failure, do not use. Bosutinib can be given in mild renal failure, 400 milligrams, in moderate 300 milligrams, and in severe 200 milligrams. There is no data for nilotinib and dasatinib. So if you use any one of these agents, then you are on a bit of a legal limb as to if there is an adverse outcome, then it might be difficult for you to defend yourself. So any comments now from my panelists regarding TKI and renal failure? Any inputs? Okay, so this is my last slide. Like as already mentioned, our CML patients now have a normal life expectancy, and this holds true only if expert management is provided to these patients. And it is our job, all of you who are leaders and experts in CML treatment, in hematology, in medical oncology, to make sure that you impart this knowledge and much more than this knowledge to everybody who's treating CML. If somebody is not treating CML, I think it is criminal negligence, and we have to convey to our young people, to some of the physicians who are treating CML, that you have to have a basic knowledge before you can do justice. And several options are now available in our country with the availability of generic, not so expensive second generation TKIs like dasatinib. TFR is a reality, but it's a reality in a minority of patients, maybe 20 to 30% of patients. And the choice of TKI, not only in the second line, but also in the newly diagnosed patients, will depend on the cost, the convenience, as Rahul mentioned, the comorbidities which the patient has, and the toxicity. So with that, I'll finish my presentation. I will stop the slide share and we will see if we can do some questions, okay? So is everybody around? We'll do some questions. So the first question is from Dr. Madhusudan, who wants to know TFR, and I think we've already talked about TFR, but he also wants to know which is the most effective drug in the accelerated phase of CML. So Pankaj, are you there? Dr. Pankaj? Okay, Pankaj is not there. Dinesh, I can see. Dinesh, can you answer this? Which is the most effective drug in accelerated phase of CML and what dose also?
I think the accelerated phase will come into the high risk. So we should go for a second generation TKIs, considering the toxicity and the other criteria is met. So probably the second generation TKIs rather than imatinib. And we should closely monitor for the response.
And a higher dose than the standard dose, right?
Probably the higher dose.
Yeah, Rahul, go ahead.
Sir, but nilotinib is not approved for accelerated phase and a blast phase. Only dasatinib is approved, sir. So dasatinib 140 milligram.
Right.
I agree with Rahul.
So we have a question from Dr. Ruchika. How helpful is early molecular response assessment in predicting overall survival? So who wants to take this? Sandeep? Dr. Sandeep, can you take this? Sandeep Shah?
Yeah, I think most of the trials it is. shown that if patients achieves early molecular response, that is less than 10% at 3 months, then chances of survival, overall survival will be high. And chances of getting deep molecular response also will be high.
Okay, so let me
It
ask
is very
Dr.
important.
Samir. Samir, do you suppose you started a patient on imatinib,
Yeah.
and there is suboptimal response at 3 months? Say the
Yeah.
BCR able is 15.55. It is not 10, not less than 10.
Yeah.
Would you change at 3 months, or would you give that patient a little more time on imatinib?
Yeah, I tend to give them a little bit more time. It's
Little bit
usually a
more time,
combination
meaning a
with
month, or you do the BCR able again at 6 months?
I tend to do it at 6 months. I don't do it straight away after a month, but we take the patient into confidence and get what the patient's views are. And if they're agreeable, I usually tend to do it again at 6 months and see what it is.
Okay. Dr. Soumya, what would you do? Rahul, I'm coming to you in a second. 1 minute. Dr. Soumya?
Yeah, I won't be changing my options just at 3 months. I will wait till the 6 months report.
Okay.
And depending on what the report is, I will decide.
Rahul, quick, crisp comment.
So, when it comes to overall survival, none of the trials, neither Decision, neither Earnest trial has shown any benefit of a second generation DKI in progression-free component. The only thing which they have been able to show by early molecular response is our ability to stop, your ability to reach to MR 4.5 at the earliest. That is the only thing which we need to remember. What is your criteria and what your treatment philosophy, that will decide.
Okay. Okay, agreed. So I have a question from Dr. Narendra Agarwal, which I will direct to Dr. Lalit Mohan Sharma. What is your choice of TKI in a newly diagnosed patient of accelerated phase of chronic myeloid leukemia? This has been covered a little bit, but you can, do it again one more time, Lalit. Lalit, are you there?
So he has left.
He left. Okay, so maybe Dr. Sada Shivdu, are you there?
Only Dasatinib, so there is only one drug approved. It's a more effective, efficacious drug. So definitely go for Dasatinib.
Okay. So last question, maybe Rahul, you can take this. Any role of NGS for somatic mutation detection in patients of CML who do not have an optimal response in current real life practice in our country?
Sir, no, sir. We have started doing it. We have started sending samples, looking out for any other mutations which are there. I don't know what to do with that. But yes, if you're doing IRMA by an NGS, that will be a good idea. But looking for a somatic mutation is the area of interest which we are pursuing. Let's see.
Okay. So I think we've covered most of the questions also. If there are any comments by any one of the speakers or any one of the panelists, brief 5-10 second comments, we'll take those and then we will kind of try and wind up. Any comments from anybody?
So only comment is that you keep on conducting every week or every 15 days such debates, sir. It is so good to hear you and the panelists, sir. It is so much learning.
Thank you so much, Rahul. I thought it was, when Rajesh and the MCure people came and said one more webinar on CML, I was a little reluctant, but it's always a little bit of knowledge gain for me, so it's fun for me. And thank you very much for those nice words. So we have a score of 303 attendees in our meeting. I don't know what kind of woman that is. So 303 people attended this, and I hope they gained a significant amount of knowledge for this most common leukemia in our country. And when they see patients from the coming week, coming Monday, they will be a little wiser vis-a-vis their approach to the patient, what investigations to do, how to approach what first-line treatments to give, which patient to think of for treatment-free remission, and particularly think of, anticipate and manage toxicities. With that, my most sincere thanks to MCure for facilitating this. for Rajesh, Kalpesh, and his team at Mice Ideas for organizing this, and for my faculty for wonderful talks, and for all the delegates who spent their Friday evening with us, and I hope they learned something. So I'd like to hand over proceedings for the final conclusion to Mr. Sanjeev Katuria. And Sanjeev, can you be very brief and wind up? My apologies for overstepping about 30 minutes into extra time. Sanjeev?
Thanks a lot, sir. And on behalf of MCure, I would like to extend my sincere gratitude to all the honorary faculties as well as the delegates. As rightly said by you, sir, almost 320 delegates have logged in for this webinar and making it a very interactive and informative session. Thanks a lot once again. And now over to you, Zoeb. You can give the vote of thanks. Thanks a lot.
Thank you so much, Anjali. I would like to thank Hemant Malhotra sir for such a nice scientific and academic speech. Would like to thank the entire panelists who we had such a great interaction. And as an MCure, we would continue to have more such events, more both especially in the field of hematology and other. And I would also like to inform that with the promise we would have an event tomorrow as well. Especially on the role of Cidofovir. So stay tuned. We can connect. You can get in touch with the local people, and Mice Ideas team is always there. So thank you, Mice Ideas team as well. And again, sir, thanks a lot, Dr. Hemant Malhotra, for making it such a successful event. So thank you.
So thank you, my speakers, and thank you, my faculty. We'll see you soon. Thank you. Good night. Enjoy the weekend.
Good night.